Mr. Chairman and committee. Thank you. I'm Ann Dunkelberg with the Center for Public Policy Priorities and appreciate the opportunity to testify on the committee substitute for House Bill 3791 by Zerwas, and we're testifying neutrally on the bill rather than either in opposition or support because the bill does include some elements that we strongly and fundamentally disagree with, but at the same time it also includes some proposals that we could strongly support if they weren't bookended by some things that we do not. So before I talked about any of the pieces of the bill that we have issues with, I wanted to first again join the chorus of voices thanking Chairman Zerwas for his leadership, and we wanted to be as positive as we could about this bill because we think it is absolutely critical that we move forward with this. And to echo Ms. Moorhead in her earlier testimony today, we really just can't leave the end of this session without a commitment to find a solution for over 1 million uninsured low-income Texas adults when we have one on the table. So we hope very much that this can lead us forward. When we say that we support a big piece of this bill, what we primarily support is the vision that's laid out in subchapter B, in section 2 of the bill, subchapters A through C, where basically the outline sounds very similar to the kind of approach that we know the federal government and the governor of Arkansas have come near to agreement on, and that does allow them to cover these adults drawing Title 19 funds, but not using the traditional Medicaid program and not using the traditional Medicaid benefit package and allowing cost sharing for that population. And to me, that sounds like an enormous compromise that Texas should be absolutely giving serious consideration to. The two things that we're most concerned about in moving forward with an Arkansas type approach of doing premium assistance rather than traditional Medicaid would be making sure that any out-of-pocket costs, as we implement cost savings, that those are reasonable and affordable, and we think the federal standards that are in place for that provide us with very good guidelines for that. And then basically, it is a very confusing matter, but as a matter of fact, for this new population, we are allowed to use a commercial benchmark for them, and rather than the traditional Medicaid package, and we support that. We think that's just fine. We do want to make sure that there are protections there for safety net providers, and as you may know, federal Medicaid now makes sure that people have access to federally qualified health centers and rural health clinics, for example. So we're concerned about keeping some of those protections of access to safety net providers, but basically we support that. Now, our concern about the final section of the bill, which is sort of the fallback if all else fails section, is just that if we are only using additional premium tax revenues, whatever the correct number for that is, it could only cover about 29,000, 30,000 people, which I'm sure those 30,000 people would be very happy, but I don't think Texas should settle for that little when we have Title 19 funding that can help us cover more than 1 million new adults. And then finally, we didn't want to, one of our core objections, as I said, is to the block grant option, even though we agree with speakers, including Chairman Zerwas, that we don't think that's likely to be approved. But we did want to give you some background on what our concerns are about block grants, and so I've actually provided that for you on the first page, but I didn't want to spend all my time talking about that. I'd be happy to answer any questions. I think one of the cautionary tale that I would close with is just that in 2012, under the TANF block grant, Texas received $294 per child in poverty, whereas New York received $2,782 per child in poverty. So those are the kinds of outcomes we are concerned about when we start talking too loosely about block grants, and we are concerned about the best deal for Texas. Thank you. I'm happy to answer any questions.
Representative Coleman.
Thank you. And just quickly, Ann, in terms of other things that you think we can do that would, so you're saying that, and this was real question, so you're saying that there's the things in this bill, most of it's good, but there are some things that would it be how we do it? I understand the block grant piece.
The block grant is only acceptable if I get to design it.
Okay, I got you. Well, just like I told Chairwoman Kokor's on the floor, if it was you, it would be a different deal. So, but the point that you made about the block grant, but on some of the other things, do you think we could find some ways to make sure that there's some any concerns on those that we could work through?
Absolutely. I think that there's an enormous amount of flexibility there, which is not to say that the federal government has no standards at all. I think that's the only thing we have to have our eyes open about. But we can't do very much without those Title 19 dollars.
And the piece on take-up rates, we had experience in CHIP on take-up rates, right? You know, based on the rollout of CHIP, and that's a pretty good benchmark for an outreach program, right?
We had great success in CHIP. We got a late start, but we had very rapid enrollment and high take-up. And
then the navigator part of this bill, with the bill under the ACA, it comes from the Medicare Part D program that used a similar type circumstance with an exchange. You might know more than I do on that topic, Chairman. Well, I didn't mean to know more. I thought you knew everything. But that is what it was based on, a portal that people could go into and then compare plans. Exactly. The idea of the exchange is, as they sometimes flippantly say, Travelocity for health insurance. Right. So they also marked, the federal government had to look at the potential take-up rate as well, right, to actually do the budget for 10 years on that. And I think that's one of the places where they looked at what kind of take-up rates they would be, because I think they modeled it on, pretty sure they modeled it on Part D. And historically, we do have obviously different kinds of take-up rates for different populations, and children's rates have typically been higher. Seniors may also typically be higher. I think this adult population that we would be reaching out to here probably has one of the lower take-up rates historically, and we would need to work on outreach.